Asia is actually one of the largest continents, and with a very vast diversity in terms of cultural as well as ethnic group, as well as even in the language. So, and there's a huge disparity in terms of income as well as the oral hygiene. What is very important at the center of my heart is that we will need to be able to give to the less developed country for humanitarian projects such as community dental service, eradication of dental caries, control of periodontal disease, which is also known to be closely associated with the heart disease as well as strokes and other systemic disease. So there are a whole range of dental problems that ICD could actually work with. This is something that I'm going to share it with the rest of the dentists in Asia as well as in the world. I'm going to make many young dentists aspire to join ICD and to volunteer their service, which is essentially what ICD motto is, to serve and to recognize the service.
The International College of Dentists is the world's oldest and largest honor society for dentists. We honor dentists who have shown outstanding merit in their contributions to the profession and to the community. We do this by conferring ICD fellowship upon them. Together, ICD fellows around the world give back to their communities by providing humanitarian dental care programs. We give back to the dental profession through dental education initiatives. We support humanitarian dental care projects in over 55 countries. We promote dental education around the world so that the best dental oral health care is available to patients everywhere.
We're trying to grow the college, and we're looking to honor every deserving fellow worldwide. I'm thinking the top 2% in the areas of humanitarian service, in education, in leadership, in mentorship. The other thing that the college is doing, and the reason that we would like to have more members and a greater global presence than we even have now, is that we are trying to become known as the worldwide leader in provision of dental humanitarian services. That, I think, is a goal that we have. It's also a mission that we've taken on because we have a great wealth of talent in our manpower, in our fellowship. We have a lot of the dental educators, the providers of humanitarian service, and we do very well in that regard between our fellows. And I think we have not just
Hello, Tato Ibrahim.
Hello, Professor Azhar, how are you?
How are you? Hi,
Alhamdulillah,
Joharia.
good. Alhamdulillah, good.
Assalamualaikum, Joharia.
Sorry?
Assalamu alaikum, sirs, to both of you. Hope you both are well.
Thank you. Thank you very much.
Yeah, I further apologize because there was some mistakes in the timing. But I just realized after 3 or 4 announcements until just now, I realized the time. I hope that we'll get people online later. All right, I think it's 9, almost time now. Maybe we can start. Somebody just asking me about password. I just correct the password again.
You send it to this council. Council, again, you send the link.
Yeah, I see. Yeah. Okay. Okay, we shall start our webinar tonight. And today, this is the month of November. This is November, and we have speaker from Pakistan. And what more? More abrupt that we are choosing. The moderator will be our vice president, and also region of Pakistan, Professor Azhar Malik. Azhar Malik, you can start the session. But now, over to you, Professor.
Thank you very much. It is my pleasure, Professor Ibrahim, and all the audience, that today I am introducing a person which is really, I'm very, very happy to introduce the magnificent personality, and very proud of Pakistan, especially with reference to the laser dentistry, cosmetic dentistry, and other field. Her topic today is OPMDs and dental laser. And very astonishingly, she says that are we underestimating and relationship? And that's wonderful how she is going to elaborate this topic. Ladies and gentlemen, she is basically a graduate from Liaquat University, and that is a very famous university in Pakistan. Then she proceeded to UK for her post-graduation. And after that, she traveled to Germany and got the very good post-graduation, which is the world-renowned post-graduation of lasers. She is an established oropathologist, not only in a private practice, but in a medical college, that is Ahmedabad, and she is now a full professor. She is proud of Pakistan because she is one of the few person which has introduced the laser in dentistry in Pakistan. I was thinking of myself that when in 1986, when I done my thesis on laser comparative study of wound healing after partial glossectomy by carbon dioxide laser versus scalpel, and I was astonished that who is going to take up this task future. But I am very proud that now in Pakistan, there are 4 or 5 very talented people who are bringing the laser forward. And the top of them is the lady before me, Dr. Joharia Azhar. Dr. Joharia, your introduction with reference to your motivation, your work, and what you have done in Pakistan for orophathology, for the women welfare work. And that's why she has been awarded by the President of Pakistan. And she is one of the dental surgeon who is being appreciated as high platform in Pakistan. I think that a few of introduction I will leave to her. And welcome, Dr. Joharia. And we expect from you that what a wonderful topic you have chosen. You are going to elaborate it in this limited period. Thank you.
Thank you so much, sir. First of all, I would like to say assalamu alaikum to everyone, to all the participants. And then thank you very much to Professor Dr. Ibrahim and Professor Dr. Azhar Malik. Listening to the introduction, that was a bit too elaborated. And coming from Dr. Azhar Malik's words, in his words, he's my mentor. So I feel really obliged, sir. Thank you so much. I think introduction has been done, enough of it. I will now straight away jump onto our topic so that we finish timely. Can everyone see my screen? Sir, can you see my screen?
Yeah, it is there. It is there.
I'm in the presentation. Can you see
Yeah,
it?
it is there. It is there.
Okay, great. So I would now start with the topic. Actually, these are two topics which are very close to my heart. As Dr. Ashad Malik also said that I really like oral pathology was my primary field, but I really love dental lasers. So whenever I can find a chance to amalgamate both of these things together, I find it to be extremely helpful and nice. And so I was very happy when I was told to choose a topic, and I chose this topic in which both of my, the subjects of my interests would be amalgamated. So coming on to OPMDs, we all have observed as healthcare workers and as dentists that with the advent of time, malignancies and cancers have really become more, they have risen. The cancer is on the rise. The cases have increased. And initially, we used to have cancer in the older age group, but now, younger patients are emerging with the malignancies. Now, the exact cause of this is not known. Still, studies are ongoing. So excuse me, I cannot turn it to the next slide. Can you just wait for a minute? Yeah, okay.
Yeah, it is there.
Yes, sorry for the interruption because I was pressing the button from my computer. It was not working initially. So anyways, I would begin by telling you what OPMDs actually are. OPMDs are oral potentially malignant conditions. Why we call them potentially malignant? Because these are the conditions which are not malignant at the time of their discovery. However, they have the potential to undergo this transformation, and sometimes they do it very, very quietly, and we are caught off guard. Therefore, the oral pathologists decided to have this separate category of OPMDs so that every dentist, whenever we come across these OPMDs, we would be, on our toes and raise the red flags to keep those patients and those lesions under observation. And they are a special area of interest for most dentists and most oral pathologists also because oral cancer is on the rise, especially in Asia. It is the second most common cause of cancer-related deaths. Therefore, we need to pay more attention towards it. Now, the OPMDs, they carry a statistically increased cancer risk. So these patients have to undergo, 6 monthly or yearly checkups in order to determine and in order to carry out the risk stratification. Some observational studies have shown that a large proportion of OPMDs, they say 1/3 of the OPMDs, usually they transform into cancers. And in this case, the grading of oral epithelial dysplasia is usually used to stratify the risk of the OPMDs. And obviously, we all know that an increase in the severity of dysplasia usually points towards a malignant change that is about to occur in a certain OPMD, which could be an innocent-looking lesion in the oral cavity, yet a malignancy underneath. So this brings us to the risk stratification, and I would like to start by elaborating what exactly is risk stratification. It's actually the process of assigning a risk status to a patient, or in this case, we would say to a certain lesion, so that improved healthcare can be provided to the patients. And this enables us, the dentists, the oral pathologists, the healthcare workers, the right level of care that we can offer to our patients. Mostly risk stratification is can be done on the clinical picture. And however, sometimes when the clinical picture is not that elaborate, we then move on to the histopathological and molecular studies. So there are just a few, factors which are mentioned over here, which we use for risk stratification. The first top 3 are the ones which we use clinically for clinical risk stratification, like the red area. If the lesion has got red areas in it, then it's more obnoxious, more inclined towards undergoing a malignant transformation. Then if the size of the lesion exceeds 200 square millimeters, again, then we consider it a high risk case. Lacanoid features having mixed blue and red and white lesion and characteristics in the lesion, it also makes it more prone to undergoing malignant transformation. Then in the histopathological field, the higher grade of dysplasia, and loss of heterozygosity. These are two very important factors which are to be considered. And we should always remember that a third of the OPMDs, they would transform into oral squamous cell carcinoma. So the algorithm of this, this treatment, how it moves is whenever we see a lesion, obviously it's under white light because our dental lights, our examination lights are white in nature. Now, there are two methods after observing the lesion as a next step. We can observe them under veloscope, which is again a light-based diagnostic device, which we can use to examine the lesion, or brush biopsy. Brush biopsy in recent years have become very, very useful in determining, the dysplastic changes, and especially in the lesions which are present in the far-flung areas of the oral cavity. So in both of these examinations, whether veloscopic or brush biopsy, the positive, the lesions which are positive. In the case of brush biopsy, the positive lesion would be considered to be the one with some dysplastic cells there. And in veloscopic examination, the lesion area which would show loss of fluorescence would be identified as positive for being an OPMD. And these are to be then referred to max-fac surgeons or to ENT specialists or oncologists for further evaluation. So these are the red flags in dentistry. Before I actually go into the laser part of it, I would like to also like to mention here that not all OPMDs are innocent looking. Some of them are really obnoxious, and like I was mentioning before, that cancer is on the rise. We are recently having more and more cases of younger patients without any apparent carcinogen present there and still showing drastic and aggressive malignancy. Now I show you here a patient. She is a 31-year-old female. And she had a history of this ulcer on the lateral border of her tongue for 5 to 6 months. And this was because of a traumatic ulcer. She considered it to be a traumatic ulcer because of a very sharp cusp on the molar. She couldn't come earlier to the dentist because she was in her first trimester of pregnancy. She used, local painkillers, local topical painkillers like Banzol. She used it. And after finishing up with her third trimester and delivering a healthy baby, she came to the doctor. By the time the ulcer had attained this picture, and we would consider the history to be just 5 or 6 months old, she does not have any drinking habit, no alcohol consumption, no smoking, but still after the biopsy specimen, after the biopsy and histopathological examination, it was diagnosed to be poorly differentiated squamous cell carcinoma. And, the dentist in her area, she was from a village, he did an excisional biopsy, and afterwards an advanced MRI was done that showed a spread, a level 2 spread, level 2 lymphadenopathy in her neck. So this would now be followed by deep neck dissection. Now, this is a very young patient, and she did not have any apparent reason, any apparent carcinogen there. Another case that came during the last 2 months. This is a 52-year-old male, again, a non-smoker. He's a practicing Muslim, so he does not consume alcohol. And obviously, there are no other apparent reasons of this. And he discovered this just 2 months. He's just giving a history of 2 months during his vacation abroad. And once he came back and we examined this was then sent for histopathological evaluation, turned out to be moderately differentiated squamous cell carcinoma. And this gentleman is now, has undergone the radical neck dissection, is now starting on his first dose of radiation. So considering these two cases were of the lesions which sort of jump at you and tell you that we are malignant because they are so indurated and obnoxious looking. OPMDs actually include lesions which are innocent looking in the oral cavity. However, they are actually hidden tigers, we can say that. So that's why nowadays we tend to pay more attention towards them, because we do not want to take it to a level where the squamous cell carcinoma is already well established. We want to do a preemptive attempt in order to prevent them, to stop them. So these conditions would include conditions like leukoplakia. Leukoplakia is defined as any patch in the oral cavity which cannot be diagnosed as any other thing. And then erythroplakia, obviously, the redder the lesion, the more obnoxious it could be, no matter how small. Then we have conditions like oral submucous fibrosis and, lichen planus. We have proliferative verrucous leukoplakia. These are the ones that we usually see, but we have other rarer variants. A palatal lesion in a reverse smoker. Reverse smoking is very common in Sri Lanka, Pakistan, and India. Therefore, maybe I'm not sure about Malaysia and Indonesia, but in these 4 countries, it's really common. And any lesion in a patient who is habitual of reverse smoking, any palatal lesion, should be considered an OPMD. Then lupus erythematosus is an autoimmune disorder, can turn into a malignancy, congenital disorder like dyskeratosis congenita. So these are the conditions which are generally speaking considered to be part of OPMDs. So how do we manage them? Usually we just start by screening and diagnosing, which helps us in reaching a provisional clinical diagnosis. Now, after the provisional clinical diagnosis, we usually start the patient on a palliative treatment, and then we reach a definitive clinical diagnosis. And this definitive clinical diagnosis actually depends on changes or lack of changes after the causative agents have been removed. Like, for example, in the case of that pregnant lady whose picture I showed you, the dentist first removed the sharp cusp and then gave a palliative treatment for 3 to 4 or 5 weeks before deciding for the histopathological evaluation. Now, the time to follow up could be from 2 to 6 weeks, but I think the sooner the better. So I would just keep it down 3 to 4 weeks. If in 3 to 4 weeks you do not see any visible change, I think it's time to pick up your scalpel or your laser to carry on the next step in this algorithm. So the next step would be the histopathologically proven diagnosis, that is the biopsy taking and histopathological examination. That is the point where a scalpel comes into the picture as well as a laser. And why I was saying that the relationship between OPMDs and laser is a little complicated and we underestimate it, because there have been studies which have shown that the use of scalpel has actually caused the cancer to metastasize either by the lymphatic spread or by direct blood insemination into the far-flung areas. Therefore, whenever we are treating an OPMD, a potentially malignant condition, laser surgery using a laser for a biopsy and histopathological evaluation should be made mandatory, because it stops the bleeding, seals the lymphatics, and seals the blood vessels that are present in the area, and hence it prevents the spread, direct spread, which can happen because of the surgery itself. So coming on to lasers now, this was just a discussion about the introduction of OPMDs. Now, laser is actually an acronym, and it stands for the light amplification by stimulated emission of radiation. So what this very a sort of complicated sentence actually means is that we take a source of laser emission, an emitting element. It is placed inside the laser body, and then we use electricity in order to stimulate it to emit the laser photons or laser waves, which are then amplified by us, and that amplified laser waves or photons are then placed onto the source, that is the human body, and that's how we treat it. So this is what the laser is. It's a little elaborate name, but very, very simple procedure behind it, pure science. How this laser is different from normal light is the normal light has many wavelengths, we all know that, while laser is only one wavelength at a time, and it's more refined. Now, if you look at the electromagnetic spectrum, this is the electromagnetic spectrum. And if you can see our tunnel vision, we can only see between the 400 nanometers to 700 nanometers over here, which is the visible spectrum. So we were given naturally a very tunnel vision by God. Anything above the 700 wavelength is infrared, and anything below is ultraviolet and X-ray. And let me tell you and reiterate another thing, that the smaller the wavelength, the more harmful the radiations are. Therefore, if patients ask us, is laser harmful for maybe pregnant women or any or such high-risk patients, or for generally for human body, it's not harmful at all, because this is the safe wavelength. This is the part of the spectrum which is considered to be safe. Now, again, it got stuck and not moving to the next slide. Yeah. Right. So these are different wavelengths of lasers which are available currently in market. And if we consider the wavelengths which are only important from a dental perspective, because we are only dentists here, and that's what we are going to discuss. So we have, I hope so you all can see my cursor here. So this is the diode wavelength, which is very commonly used in dentistry, the 810 nanometer wavelength. And then this is another diode, indium, gallium, and strontium. This is 940 and 980 nanometer. These two are very nice laser wavelengths, which are used in dentistry, diode wavelengths. Then we have the all tissue lasers like erbium, chromium, YSGG, and erbium YAG here. Their wavelengths fall into the 2000s and above. So they are really big wavelengths. And the carbon dioxide laser that Professor Arshad Malik was also mentioning, which he used in 1986, maybe one of the oldest lasers to come into the market is carbon dioxide laser, and its wavelength is 10,600 nanometers. It's quite a big wavelength as compared to the diodes and the other more recent wavelengths. Now, these are the different types of lasers, and they are placed in terms of their indications and use in dentistry. So we have soft tissue lasers, which are the diodes, the Nd:YAGs, and CO2. Why CO2 laser is placed here in soft tissues? Although it can cut hard tissue, it can cut bone, it can cut the teeth, but it usually produces so much heat that it damages the tooth and the bone. Therefore, it was not considered to be a favorable wavelength to cut bone and tooth. However, I'm hearing there are new machines coming up which are removing that problem of the heat, and it now cuts bone very, very nicely. I haven't yet had an opportunity to perform with that CO2 laser, but there is only one company in the world that is producing that. Then we have the hard tissue lasers, erbium lasers, and then these both soft and hard tissue lasers. You can say the Mercedes-Benz or the Porsche of the dental lasers are the erbium chromium YSGG by the BioLace company and erbium YAG. These are the two laser wavelengths which can cut and affect both soft tissues as well as the hard tissues in the oral cavity. Now, modes of treatment of lasers are really different, and I, at the moment, do not have the time to really explain it, but just a little bit, I would just be mentioning it that there are various modes and parameters in the laser physics that determine its dosimetry, and the dosimetry can actually then control the way a laser cuts. So different treatments, what type of cut we need or what kind of treatment we want to carry out depends on the laser parameters. For example, do we use a focused beam or do we use a defocused beam? What would be the spot size? What would be the laser power density, frequency, pulse length, pulse duration? There are so many of these things that can ultimately determine, as you can see, the extent of the cut, the type of the cut, the shape of the cut more than 250 micrometers in depth or cut less than 250 micrometers in depth. And then there are these super pulses, which are extremely painless surgery with these new handpieces with super pulses. They say that you won't even feel a thing, and anesthesia usage has really been reduced to negligible or zero with these newer machines. So having said that, I just wanted to reiterate that laser physics plays a fundamental role in this field. And if you know your laser physics completely, then you can use the same machine and use it to perform various procedures by changing the dosimetry a little bit from here and there. One thing to note here is that the photobiomodulation therapy and the lower laser therapy is totally contraindicated in any lesion which you're considering to be potentially pre-malignant. And the reason behind this is that photobiomodulation therapy and lower laser light therapy actually increases microvasculature and increases the growth capacity of the tissue and gives it energy, so to speak. And we do not want our pre-malignant lesion to have this, to attain this potential to, grow and become a malignancy before. Therefore, always when you're using photobiomodulation therapy and lower laser light therapy on a patient, it has to be, we have to rule out OPMDs in that particular region. Now, coming on to the relationship, which is very complicated between OPMDs and lasers, there are 4 or 5 procedures which are important in terms of laser physics. If I use these names like photochemolysis, photopyrolysis, then there's photothermolysis, then there's photoviprolysis, then there's photoplasmolysis. Now, these are laser and tissue interactions, and clinically, they get translated in the form of cutting, coagulating, ablating, and welding. So these are the terms which we are more familiar with. We know how to weld, we do know how to ablate the tissues or coagulate or cut the tissue, but these processes have the other processes underlying them, and those I have mentioned. Now I would be removing the others and only restricting for your viewership the ones which are present in our dental lasers. So the dental lasers, diodes and NDX, they work on two principles, photopyrolysis and photothermolysis. Here, photopyrolysis simply means heating a tissue below 100 degrees centigrade. So in order to cause welding or coagulation effect. And photothermolysis means heating a tissue more at a temperature of more than 100 degrees so as to bring about thermal necrosis, meaning cutting and ablating of tissues. So this is how diodes and NDX, they perform their function. Then we have the other process, photovaporylysis, which is a process that is used in the erbium, chromium YSGG, and erbium YAG lasers to cut all soft and hard tissue. This process simply means heating the water which is present in the cell to an extreme temperature so that that water in the cell suddenly turns into a steam, disrupting the architecture of the cell, killing the cell and removing it. So there are small bomb blasts, so to speak, in the tissue. So erbium YAG lasers, this is how they cut, and this is how they remove even the tooth tissue by producing these micro explosions onto the tooth surface where the water is evaporated and the tissue is removed. Now, this is another, association. This graph shows a very nice association between the different laser parameters, which we use daily. This is just a little example that within the same laser box. Why I'm showing this actually? I was doing once a photobiomodulation therapy for my mother and for her joint. It was for her pain in the joint, and I told her I'm using the same machine to cut the tissue, and she became very apprehensive and she asked me that you are doing pain therapy for my joint. What if the laser starts cutting it? And I told her it will not start cutting it. And why? Why won't it start cutting? And why do we have these two totally different, totally different procedures that can be performed by the same laser? This is how we can have that, because we have this power density and its relation with the pulse duration. If you look at the graph here, at this point, we have a very large pulse, which is long pulse, but the power density is very less. And at this point, at this juncture, it is doing biostimulation. So if we have to do any treatment which involves biostimulation, like enhanced orthodontic tooth movement, or we want to control the pain of neuralgias, this is the place where our parameters would be, with the long pulse duration and very low power density. Now, if we decrease the pulse duration and increase the power density, then it goes up in an invasive mode. And here at this point, then the laser would now start performing photopyrolysis, which means coagulation. So if I have got a hemangioma and I want to control the bleeding, this is the parameter, this is the point that I would be using. Now, decreasing the wave, the pulse duration further and increasing the power density further, then I would reach the point where photodisruption and finally photoplasmolysis, that is tissue removal, would be done. So the same laser, if I keep the pulse duration very small and power density more, I would be cutting the tissue, and we're using the same laser. If I keep the pulse duration very long and the power density very small, I would be stimulating the tissues. This is the power of light. This is the power of laser, and which is really awesome, as good as magic would be. So there are different other mechanisms and parameters that come into play in the creation of laser dosimetry. There's pulse duration, pulse length, there's power density, frequency, and the total power of the laser machine. And that's why laser physics plays a very important role in these different treatments. Here's another example of this. If you look at these two photographs, this photograph over here is a carbon dioxide laser, and this photograph over here is a diode laser. Now, both of them are cutting a chicken leg. And this is just for you to appreciate between the type of cuts. You see here, this is 7 watts. The power is 7 watts of CO2 laser, and the spot size is 0.25 millimeter. Similarly, in the diode laser, it has got parallel, parameters. It's the diode laser with the 7 watts power and 0.3 millimeter spot size. Things are almost the same. But look at the cut of CO2 laser and look at diode laser. It has barely scratched the surface. So if next time you hear someone saying that I bought a laser, but it doesn't seem to work, that does not mean that the laser is working. That simply means that the optimum parameters are not being used. So just the parameters need to be tweaked. And once you tweak the parameters, you can perform any function using any laser. Now elaborating more on that relationship between OPMDs and laser, which is considered complicated. And most of the surgeons, they usually hate these, especially they hated it in 2013. Sir, Dr. Ashad Malik is a surgeon as well, but he loves lasers. But there are some who really hate lasers and they don't believe in all this. This is a study, a very nice study, which was done determining the post-op complications in a laser group, in a group where the histopathology was done using a laser, diode laser, which is being shown here on the left side, and then the traditional conventional blade biopsy that is shown here on the right side. As you can see, post-operative things that post-operative factors that were observed were pain, edema, hematoma, and satisfaction, overall satisfaction of the patients. And it can be seen that the pain as well as edema as well as hematoma formation post-op in the post-op area were very, very less in laser group as compared to the scalpel group, and patient satisfaction was very, very high in the laser group as compared to the other group, the conventional scalpel group. Apart from that, with lasers, we have enhanced infection control, obviously. We have microsurgical capabilities, which I would also show you now shortly in a little video. And usually these procedures become in-office and OPD procedures. There's no need to admit the patient, and reduce or no requirement of sutures post-operatively, no requirement of antibiotics post-operatively. Even hardly I have ever given analgesics as a post-op to these patients. We just write down paracetamol, SOS if they need it. And usually these patients don't even need that post-operatively. So this is how good this capability of lasers is. Just a little look at the changes in the healing process and comparing them in the conventional scalpel surgeries and then, the laser-based surgeries. In the conventional surgery, we have this barrier clot that first comes, and this is followed by inflammation and swelling, which is followed by tissue regeneration and finally tissue remodeling. And after remodeling is finished, we consider healing process to be completed. However, when you are doing the same thing with the laser, you see barrier clot is not formed there because coagulation capabilities of the laser, especially of diodes and anti-ags, they do not cause any bleeding. So there's already too much coagulation, melting of proteins there, no bleeding. Inflammation is modified, so you have just a small healing phase of the inflammation, which is followed by tissue regeneration and tissue modeling. So you see the whole cascade shortens and healing occurs very, very quickly. That's why now, on the face surgeries, where in the static zone especially, we now prefer lasers because they do not leave any scar behind, or they heal very quickly. Now, the advantages in OPMDs is, number one, is that the recurrence rate is reduced to approximately 20% due to deep penetration of laser beam. Now, this is the point that I was even mentioning before, that we sometimes do when we are doing a scalpel surgery on an OPMD. It's always at the back of the mind that this blood that is flowing down in the throat and in the other tissues could be taking the malignant cells or a pre-malignant cell down there, resulting in direct seeding of that tumor at a far-flung area. With the use of lasers, even that danger is removed. Then sealing of microvasculature and lymphatics, they reduce chances of seeding and hence they reduce the chances of metastasis. And the advantages are more attributable to technical parameters during surgery than to oncological factors, of course. And that's why this is technically a more laser thing than a more cancer thing. The cancer might not have spread otherwise if sometimes spread is caused by the histopathology itself. And there is a very strong group of histopathologists that actually believe this to be true. But still, there are debates are ongoing between the two groups. Anyway, so these are the advantages of the lasers in OPMDs. And I would say that if we consider these advantages, it would be made mandatory to carry out the biopsy of all the OPMDs using lasers. instead of the scalpel. Then sometimes I have also heard from histopathologists and pathologists alike that doing a laser surgery, the thermal induced artifacts are produced in the tissue, and hence the histopathology can be a little hard to decipher then. But I do not agree to it. I would show you now 3 different videos with 3 different kinds of cuts taking place. And, in all the cases, the surgery was performed and histopathology was performed. Let me play this one. This is a relatively bigger, papilloma present on the palatal side of this patient. And this is big, so not a problem even if you do a scalpel surgery or a laser surgery, easier to be done and then easier to be sent to the histopathologist for histopathological examination. So here is the specimen when it was taken out, its gross appearance before it was sent. Now the other one, this one is an example of the microsurgery. And I couldn't find in my library the video for the microsurgery of an OPMD. This is a mucocele that is being removed very nicely and in a very intact way. We ended up removing the whole cyst in an intact method without rupturing it. And what I wanted to show is the cyst is here, followed by these 2 feeding glands. The small glands, the minor salivary glands that were feeding it, were removed during this microsurgery. Now, this cannot be attained if I was using a scalpel. So if you want to do microsurgery, then lasers are the answer. Now, this is a leukoplakial patch which is being removed, and here is where I want to refute what some histopathologists say, that the mucosal patches and scrapings cannot be sent for histopathology. If you see that the direction of my tip over here is a little different than the direction that was used in the other 2 surgeries. With this direction and a little change in the methodology, we can send these mucosal scrapings for histopathological evaluation for a leukoplakial patch. So this was not a problem at all if you have an experienced hand. With this, I come on to the diagnosis of OPMDs and would like to introduce Veloscope. Veloscope is not new to dentistry. It was, I think, back in early 2000s that this was actually brought into market, 2004 maybe, and it's a very nice tool to have in your practice. It actually throws a light onto the tissue. Normal tissue absorbs it and emits as fluorescent, which is light green in color. So all the normal tissue would appear light green. However, any area which would have a pathology underneath it would appear darker. So it's the darker area that you can mark, and the dark area would actually represent the presence of an OPMD. This is a screening tool. Please do keep in mind, this is not a diagnostic tool. It will only identify the area which could be either dysplastic in nature or inflammatory in nature. The final diagnosis would always depend on either a brush biopsy or histopathology, but it certainly helps you in screening and in prevention. As you can see from a few examples that I have included here, here is the lateral border of the tongue that appears that appears sort of normal under normal white light. However, when observed under the veloscope, over here you can see the dysplastic changes or the pathology underneath the mucosa, which can then be marked and very easily removed using a biopsy or scalpel or a laser, whichever you have. A few other examples of the same lateral border of the tongue. Again, some areas of denuded epithelium can be seen. However, the veloscopic examination shows a lot of loss of fluorescence, LOF. Like in this second lesion as well, you see a small denuded area here on the lateral border. Without a veloscope, you'd just be removing this circle here, but once observed under the veloscope, you can see the extent of the lesion that extends and or probably present about along the whole length of the lateral border of the tongue. So it was then removed. Similarly, on the buccal mucosa, this is a small lesion. However, veloscopic exam shows you the loss of fluorescence over a wider area, which then margins are widened when treating this area. This can also help us in the identification of satellite lesions. Like, for example, this was the lesion initially under white light. Veloscopic examination, as you can see here, shows that this was later onwards diagnosed as the carcinoma in situ. Here, the blue color here is toluidine staining, and then later, in the same lesion, you can see a dark area here, which was the satellite lesion. And toluidine blue, interestingly, did not mark the satellite lesion. So toluidine blue staining would have missed the satellite lesion here, but Veloscope identified it, and hence it was sent for histopathological evaluation. Another example of the determination of surgical margins, which can appear very small on white light examination, but under the Veloscope, the exact extent of the lesion becomes apparent. So this is one of the applications of lasers in OPMD's diagnosis and prevention that can become very helpful. Now, just I would like to touch a few OPMDs in a very short way, because the time is also of essence. So I thought I'd put forward lichen planus. Lichen planus, I've had the opportunity to treat a large number of lichen planus patients here, because apparently it's more common than what we would like to say. This is the typical appearance of the lichen planus with Wickham's striations, and a clinical diagnosis can be made just by looking at it. However, sometimes erosive lichen planus is also there, in which case the diagnosis becomes a little bit difficult and histopathology has to be done. The usual mode of treatments are the topical corticosteroids like analog and oral base or clobetasol that are given to these patients. These patients usually have significant pain, especially in erosive lichen planus cases. There's weight loss or nutritional deficiencies in these patients because they can't eat properly. Stress or anxiety develops then, and depression. Erosive lesions leave behind scars, and they have secondary fungal infections, and this is a potentially premalignant condition, can lead to oral cancer if left as it is. It is recalcitrant to treatments. So mostly you'll come across these patients who would have spent years and years in taking those topical steroids, and still nothing would have happened. A few cases, this is my best case so far, and I like including it in all my presentations because this patient is still to date lesion-free. This is a gynecologist, and she had erosive lichen planus on her maxillary mucosa, and she had the typical lichen planus on her mandibular mucosa, which was not hurting her. Therefore, she was only interested in treating the maxillary mucosa. And so we treated surgical, we did the surgical removal in this case, although we can do a non-surgical as well, but she opted for the surgical one, and the maxillary mucosa was treated. This is immediately after. And this is the patient, a diode laser was used to treat this patient and remove her, the upper layer of her mucosa. So this is her post-month, this is her 4-month post-op. As you can see, the new mucosa looks very healthy and disease-free. And then this is her 6-monthly post-op. As you can see, still there was nothing there. Sorry, 9-monthly recall. There was still nothing there. And then I don't know why the slide stops moving after some time. Yeah. So this was her situation in 2020. We called her, and those were the days of the COVID lockdown, and she took a picture and she sent her. Her mucosa looked normal. She still hasn't had a recurrence of that since it was treated back in 2013. And we usually save the photographs in folders with proper dates there. Therefore, we do have a follow-up, 5 or 10 years follow-up. This is another patient, right? Cheek treatment for the on the buccal mucosa that was carried out in 2014. As you can see, again, surgical treatment is being carried out, and the whole mucosa after veloscopic examination, the extent was marked, because you can see here under the white light, it looks small, but still we ended up removing quite a lot of it because of the veloscopic boundaries that were identified to be more than what could be seen. And this is her after 6 months, and this is her after how many years it is, sorry. Yeah, so this is her most latest picture that I have right now. In the moment, this was in 2020, and you can see most of the mucosa is without the condition. However, a little bit of it seems to be appearing from here. So this has probably given her 6 to 7 disease-free years, and now it is appearing again. That's what I was saying, that the lasers can actually help such patients a lot, the recalcitrant case especially. Then this procedure was done on the other side of her oral cavity. Same way, you can see immediate post-op, there was a little bit more blood than usual. In this case, this is was her 9th month recall, which showed a lot of fibrin activity. And this is her again in 2020, when she still appears to be disease-free. In most of these patients, we first do the veloscopic screening. We mark the borders, and then we carry out the laser removal. As you can see here in this patient, there is a small lesion, lichen planus, on the buccal mucosa under ordinary light, but under the veloscopic light, can you see this loss of fluorescence, LOF here, which appears to be very dark. It was quite huge. And so this whole area was then removed using the lasers in this patient. So this is her 3-monthly of the same patient, 3-monthly recall after the treatment. And this is another patient who had active hepatitis C infection with lichen planus, and she had a recalcitrant hepatitis C, which was not responding to interferon, and she had interferon ongoing treatment at that time as well. And when lichen planus appeared in her oral cavity, and now lichen planus has been known to appear in association with either, hepatitis C or interferon. Exact association has not been established yet between these two factors. This is her immediate post-op and the 14th day post-op after the treatment. On the two sides, as you can see, the two sides. This was 1 year and 2 monthly recall, where you see slight lesions reappearing because she had hepatitis C infection, and now it's also appearing on her gingiva as well. So the purpose actually of showing you these slides, this is her 3-year recall, and on the 3rd year recall, you can see the full disease is back. So every patient is different. I mean, we cannot really predict after seeing a patient that if we are treating them with a laser, the condition is going to go. So that has to be communicated to the patient at the start of the treatment, that how soon it would recur depends on the underlying condition or whatever is causing it. Since it's immunological in nature, we really cannot comment. In some patients, like the first case that you saw, the patient is disease-free till to date, but the other patient was disease-free for 6-7 years, and this patient only remained disease-free for around 3 years or so. But still, I mean, it gave her some time which was disease-free. So this is the same patient. Her 3-monthly recall, then 1.5 year recall, and then her 3 years recall, which was most latest in September 2016. And probably after 2016, after the recurrence, she became a little disheartened and she stopped responding to our queries that whether the lesion is still there or would she like to have another go at this treatment. So the laser interaction in this condition with the soft tissue is a very precise and a very small cut. So for mucosal pathologies, which are included in the OPMDs, like the leukoplakia and lichen planus, which are mostly restricted to the upper layers of the epithelium, there's nothing much you can do if you do not have lasers. So lasers can be the only answer to it. Again, I would say that they then become mandatory tool in such conditions. If you look at the histopathological picture over here, which is of a diode laser that has one pulse or one shot of the diode laser that has removed just a very small minute part of the epithelium, and the redness that you see underneath it is the cause of the no bleeding that occurs in these cases. So we have a bloodless surgery. So what we do is this: we keep on removing the epithelium on the two sides. The pathology along with the epithelium gets removed and gets sent for the histopathological evaluation. The new epithelium that comes is healthy, and the patient remains disease-free for, we can't predict for how long, but for a long period of time. Now, this is the same cut using an Nd:YAG laser. Again, you can see a very small and precise cut with one pulse, and there are no underlying scar or anything. The underlying tissue looks absolutely normal. This is the beauty of these treatments. We can carry out a photocoagulation of lichen planus. That would be considered a non-surgical treatment of this. And the principle behind that is, if you see, this is the epithelium. And under the epithelium, these purple dots are all the lymphocytic infiltrate that comes in the patients of lichen planus and causes the pathology. If we remove the proteins which are expressed by these cells in the basal cell, These proteins are ICAMs and VCAMs. They are adhesion proteins. If we remove them using photocoagulation, we leave the epithelium intact, only the proteins are coagulated and removed. This band of infiltrate would go away, and the patient again would have a disease-free period for some time, maybe 3 months, 3 years, or 7 years. However, since this treatment needs 4 or 5 sessions, the patients usually opt for the surgical treatment because both of them are obviously pain-free. The patient does not feel any debilitation or anything, and there are obviously no stitches. Now, let's take a look at the leukoplakial patches. I just shared with you the lichen planus cases. Now this is leukoplakia, very thin mucosa usually involved in leukoplakia, and usually the pathologist or histopathologist or oral pathologist can comment that how you would take the sample out with the laser. It could ablate the whole epithelium. But if you are careful with your incision and with the direction of your tip, you can actually have intact pieces of epithelium that can be sent to the histopathologist for the examination. So here's the leukoplakial patch, a very small one. This was a young girl, the daughter of a dentist, and we removed this leukoplakial patch using a diode laser. And the diode laser in this case would need an initiation of the tip. And this is the procedure. During the procedure, this is how you see the tip now goes parallel to the lesion, and the scrapings you can see on the tip. These scrapings are then collected and then are sent for the histopathological evaluation. So this is immediate post-treatment of the patient. Immediate post-treatment, it would appear a little white because obviously there's fibrin activity there and fibrotic clot is there. So you have to reassure the patient that this is not the lesion itself appearing. This is just the clot that would be removed after remodeling would be completed. This is a 1-week follow-up of the same patient. And then this is 2 weeks follow-up. As you can see, the area, it's almost disease-free. The fibrin clot has been removed and remodeling is now carried out. The epithelial histopathological examination was carried out, and it was considered to be only hyperkeratosis. There was no dysplasia seen over there. So this is another case of leukoplakia. This is a dentist who was a chain smoker, and he had very fatty, big buccal pads, very difficult to reach these areas. And he had the leukoplakial patch on the just above his molars in a far-flung area. You can see the leukoplakial patch. Again, laser was used to remove it. And this is immediate post-op after the laser removal. As you can see, there's no bleeding and nothing in that area. He is now, afterwards, he went and to pursue his PhD in Canada. And then I had to message them and ask about the patch, and it was still, he was still disease-free. So what I have observed is for the leukoplakial patch, if you remove it using a laser, it would not recur, unlike lichen planus. So a few important steps, a few important facts actually regarding the good effects of laser that laser has on the connective tissue. Now you see there is a tissue that the laser is directly getting absorbed into and removing it. Then there is a tissue that is surrounding that tissue which is getting absorbed. That tissue undergoes very nice changes because of the laser application. The laser that falls on that tissue gets absorbed into the mitochondria, and there's a particular substance in the mitochondria which is called as cytochrome C. Cytochrome C gets activated whenever it is exposed to any light with the wavelengths of 630 nanometers to 1000 nanometers. And please remember, our diodes, they fall into 3 wavelengths, 810 nanometer, 940 nanometers, or 980 nanometers. So they get absorbed into the cytochrome and mitochondria. And what the mitochondria does is that it can then activate a lot of transcription factors and a lot of molecular pathways. There are just a few, 2 actually, that I'm showing you here. This is the mitochondrial activation because of laser, and NF-kappa B pathway is activated. NF-B kappa pathway, once it is activated, it enhances macrophage movement and enhances the fibroblast movement and fibroblast division. It enhances the the tissue remodeling and removes pain. So it has got an overall regenerative properties. And then AP1 pathways, another transcription factor, AP1, and AP1 pathway also activates the repair in the body. So any trauma that is inflicted on the tissue because of a laser would get healed very, very quickly because it's a molecular level medicine, and the molecular level effect is being produced in the tissues. The tissue or the cells underlying the cut surface undergo lower laser light therapy like effects, and low laser light therapy reduces the healing point by stimulating various factors. A few of them are mentioned here, that it increases leukocyte activity, increases macrophage, and we all know that macrophages are the vacuum cleaners of the tissue. They come and they remove all the debris, so it becomes a very nice, clean, healthy tissue once it gets repaired, and it accelerates the wound healing. And then, laser interaction with the tissue actually has various thermal, biochemical, bioenergetic, bioelectrical effects. There are so many, just a few are mentioned here. But what happens at the end? Clinically, what we'll see is that we'd see reduced spasms, we'd see pain relief, we will see increased circulation in the local area, improved flexibility and function. So even when we are removing the lichen planus lesions from the buccal mucosa, the flexibility of the cheek is not compromised, and the patient would not feel any pain while moving and swallowing afterwards. And then there's also improved healing that we have mentioned already. So the take-home message from this discussion is that this relationship is very, very underappreciated. Lasers are underappreciated in dentistry generally, maybe because they are too expensive, but I don't think so. They're that expensive that we can't afford to buy them. Because have you, I would ask a question, have you seen any, these days, have you seen any ophthalmologist clinic, a good ophthalmologist clinic without an eye laser there? So I keep on asking the same question. How many good dental clinics or dental setups do we have that employ full-time lasers in their practice? So it's a complicated relationship, but we need to change that, and we need to bring the change which is required here. Take-home message is that laser treatment is minimally invasive treatment. It's molecular medicine. Nothing else can really interact at a molecular level. Better treatment results we get than conventional methods, of course. It's a natural organic intervention. So when patients ask you what are the side effects, there are no side effects unless you're using wrong parameters and burning the tissue. But that is then a technical fault, not the fault of the laser. And it's regenerative medicine in the true sense. Even when you are removing tissue, you are actually causing a regeneration in the tissue underlying it. So it's regenerative all in all. And this is us after we have emerged from the very bad COVID era, thankfully, and hopefully we will be able to emerge from the rise in the different malignancies and cancers that are hounding us. They are a burden on our economy. And let's use then tools like lasers in order to prevent OPMDs from turning into malignancies. And let's stop this burden on the healthcare sector as well as on the economic sector of all the countries. Thank you very much. And now if there are any questions, I think I finished well in time.
Thank you very much, Dr. Joharia. There is one question you can see in the chat. There is one question. You can read that question.
Yes. How do we regulate it? The amount of laser emission that we might use on the wound or site. Lasers are known to have carcinogenic properties if misused. These are actually one comment and one question. The amount of laser emission is can be controlled by controlling the spot size. So we have, tips with different diameters. You have 2 micrometer diameter tip, you have 4 micrometer diameter tip, which are used for cutting purposes. You have 6 micrometer diameter tip, and then you have the photobiomodulation handpieces, which have the width of around 5 centimeters. That means the spot size or the beam diameter becomes 5 centimeters in those cases. So this is how you can actually control the I wouldn't use the word laser emission, but this is how you can use the power density that is placed on the tissue. And your second comment is lasers are known to have carcinogenic properties. Not at all, even if misused. If by misused you mean that we use lower laser white therapy on an already existing malignant lesion, then it would cause the malignant lesion to spread maybe. but it is not at all a carcinogen. This is not true at all.
I agree with you. I agree with you that there are carcinogenic radiation, and these radiation has certain parameter on the living tissue. And these parameter, if the radiation do not fulfill, it is not carcinogenic. And if the parameter is within that limit, that is ionization. And if ionization is there, and it is going to change the parameter of dysplasia and anaplasia, that is going to have the carcinogenic effect. It has been theoretically approved, and it has been so many studies it has been done that the laser light do not go for the mutilation of the tissue. However, if it is already there, and if it is already in progressive way, you are going to introduce the photobiomodulation. That is, I think that is sign of interrogation, because you are providing an ATP to these carcinogenic cells, and that results into sometime drastic way. But when it is not established and you are going to treat it, and it is a pre-malignant state, I think that it is not any contraindication or there is any limitation. I think you can close the sharing of your slide.
There is another question.
Yeah.
There's another question that says, I would like to ask about how lower laser light therapy talk. There are several aspects in laser, such as wavelength, type of laser, distance of application, duration, pulsation, influence. Yet the formula for power density only include power multiplied with duration of exposure to be divided with exposed area. So how we define the dosage? The dosage, actually, this formula that you have very rightly mentioned has been given by the physicists. So I don't think I'm capable enough to challenge the physicists that why did they give this definition for power density? This is what they said. However, regarding dosage, the dosage does not include only power density. It includes a number of other things. It includes frequency, to be very precise. Frequency means the number of pulses per second. So frequency plays a very important role. And then, you know, the diameter, the pulse diameter, pulse duration, the diameter of your tip, the spot size. These are a few things that are included in the dosimetry. The distance from the tissue of the laser handpiece, focused or non-focused. We do work with the non-focused handpieces as well. And with the non-focused handpiece, the the power density is totally changed. Therefore, the dosimetry is actually a combination of all of these things together over time. So, and this is a very short time to be actually, elaborating on all of these factors of the dosimetry. So this is how we standardize the treatment. A standardized treatment would have the laser wavelength, the pulse duration, the frequency, the exact power density, and the exact tip diameter that has to be used with that particular treatment regime, and also the distance, contact mode or non-contact mode, focused or non-focused. So this is how the dosage is calculated. I hope this answers.
Yes, it is an excellent answer. Moreover, there is one thing more, that what the wavelength you are using, what type of laser you are using, what is your thaw period, and what is the nature of the tissue which you are operating. It is a fat, it is a epithelium, it is a muscle, or what type of tissue you are getting, what is the age of the patient. According to the age of the tissue, it is very dependent how much fibrosis is there, and all these things are under the parameter of joules. And what you are mentioning, actually we are calculating the joules per mentioned area squares, and that is these all doses, wavelength, and distance, parameters, thickness, and all these things are very important to be understood.
There was someone who had raised a hand, but they have now removed it. So if there is any other question, you can ask now.
Amy is actually orthodontician, prosthodontician, and she's a very, mashallah, excellent in Indonesia, and she's working a lot in postgraduate work. Amy, you have any question you can ask? Amy, right there? I don't think that she's there. Any person who like to ask any question to Madam, this is a big opportunity that she is before us, and she is mashallah competent laser operator. And now that things Datu Ibrahim, it has changed in Pakistan as well, that in approximately 20 years back there were no any academy or the teaching training centers like the Dr. Joharia has established in Pakistan, and people used to go to Germany, or people used to go to UK, or even in Pakistan there was only one center, that is Atomic Energy Commission, where we used to have the training of laser. And now it is the many centers in Pakistan who are giving laser, and World Laser Federation has recognized all these center as well. Datu, I think that all the things are done very nicely, and I am thankful to Dr. Joharia for her excellent presentation. It is over to my chairman scientific committee, Datu Muhammad Ibrahim.
Thank you. Thank you very
There is,
much.
sorry, there is one other question.
Yeah. Okay.
There is one other question. I'd quickly read it and just reply to it very quickly. I would like to ask about photodynamic therapy. It is reported with antimicrobial effect, but laser exposure without photosensitizer also have antimicrobial effect. So what is the benefit in using laser with photosensitizing agent, and the advantages of using it on mucosal tissue under microbial biofilm that is actually targeted? Thank you very much. This anonymous attendee seems to be asking really nice questions. Actually, without photodynamic therapy photosensitizer, we are usually using diodes and anti-Ags, and for diodes and anti-Ags, the chromophore is pigment. So the pigmented bacteria, which are usually the anaerobes, they would definitely get killed because of it. If you were using erbium chromium VSGG laser, then all bacteria would be killed, because all bacteria have water in their bodies, and the water would burst and the bacterial body would disrupt. But if you're using only diode and anti-Ag lasers, then you would be killing only the pigmented bacteria. And so for killing all of the bacteria for an optimum periodontal treatment, then you'd need to do PDT, photodynamic therapy, and introduce a photosensitizer for aerobic bacteria and for non-pigmented bacteria. So I hope this answers.
All right. Thank you. Thank you very much, Dr. Joharia.
Thank you so much, Dr. Ibrahim. Thank you.
Thank you also to Professor Azhar Malik for sharing our tonight's sessions. And of course, on behalf of ICD, I would like to thank both of you, the speakers and the moderator, for sharing. But I apologize for some glitch in the initial part of the meeting tonight, because in the announcement they will put 9:30 in the morning, but I can see that many of our friends know the timing is 9:30 at night. Alhamdulillah. So we should got quite a number. We got about 40 who are registered for our webinar tonight. Thank you very much again. As usual, I'd like to make announcement for our next month's meeting. Next month's meeting, we will have a orthodontist. She's going to talk about design efficiency, material feasibility, and technique proficiency for better outcome of resin bonded prosthesis. The speaker is Associate Professor Dr. Siti Mariam from UITM. So do join us on December 14 at 9:30 p.m. As usual, our time, and hopefully we can have another good session next month. Again, thank you very much for joining us tonight, and thank you again to Professor Joharia and Professor Azhar Malik for conducting the session tonight. Till next month, see you then, and inshallah we meet again in 1 month's time. Thank you.
Thank you so much, Dr. Ibrahim. Thank you, Dr. Azhar Malik, and thank you to all the participants. Have a nice evening.
Thank you.